Good morning everyone. My group is going to share about the patient reflection video. My name is Ho Yin, 30364498550. For my part, I'm going to talk part A. I'm going to talk about my patient. My patient is Mr. He's a 7-year-old retired construction worker with primary education. He now lives with his wife in public housing flat in Lantine. He's a smoker who smokes more than 15 cigarettes a day. Socially, Mr. Has a limited family network because he has minimal contact with five adult children for more than 10 years. He still has some social connection through morning teas, neighbors, and community gatherings, which gives him a sense of belonging and help reduce isolation. However, living in a cramped 100 square feet flat also creates daily challenges, especially for mobility and exercising. In terms of clinical history, Mr. was diagnosed with pneumoconiosis for more than 50 years and has around 10% of functional loss. Over time, his condition has led to chronic shortness of breath, chronic coughing, and persistent chest tightness. He also experienced a pneumothorax in late August and required surgery at United Christian Hospital, which became a major turning point in his illness experience. More recently, he also found to have a malignant node near the sternum, which also adds further physical and emotional distress to his already complex condition. Moving on to the next part, I will use symbolic interactionism to explain his illness experience. To begin with, the first core idea, human act based on the meaning things told for them. The principle means that people do not respond to health behavior because they are told to do so by professionals. Instead, they act according to the meaning that they personally attach to those behavior. For Mr. Smoking is not simply a harmful habit. For many years, it presented comfort, familiarity, and a normal part of his daily life. As a retired construction worker, smoking may also have been tied to his occupational identity and past lifestyle. Because of this, he did not immediately see smoking as something threatening. Instead, he feels smoking was a part of who he was, so refusing to quit was understandable within his own meaning system. The same applies to the physiotherapy and exercising. At first, he may have seen exercise as tiring, uncomfortable, or even pointless, especially when he was already physically weak. To him, exercise may have symbolizing extra work or reminder that his body was declining. This is why he was reluctant and needed time to accept. In symbolic interactionism, this is not simply laziness, but it is also a response to meaning he gave to exercise. Moving on to the next part, meaning arise from social interaction. This principle explains that people develop their understanding of illness and health through daily interaction with others. Meaning are not only created in isolation, they are shaped by family, friends, and peers, and also healthcare professionals. Mr. M's identity as a construction worker has been fostered through his social world, especially through morning teas. This interaction helped him to continue to see himself as a socially active man rather than a sick patient. In other words, the meaning of his life was still connected to his past occupation and social roles. At the same time, his experience with the healthcare professionals and healthcare system also shaped his behavior. If he felt that doctors were rushed and not have time to listen to his concern, he may have interpreted the clinic was a place where his voice mattered less. When he noticed that his chest tenderness were not fully explored, he may have learned that it was better to remain quiet and accept instruction passively. Third, meaning are modified through interpretation. This principle is especially important in Mr. M's case because it explains changes over time. Symbolic interactionism says that people are not fixed in their belief. They continuously interpret new experience and adjust their feelings and understandings. Our health promotion package gave Mr. new symbols and experience. The poster, weekly planner, and educational video not just education material. There were a new message about what smoking, exercising, and self-care management could mean. For example, the video shows that breathing techniques and park equipment may have helped him see exercise as something rather meaningful rather than painful. Over time, he may have started to interpret exercise as a way to reduce shortness of breath instead of as a burden. His use of nicotine patch therapy also shows his process of reinterpretation. Even if he did not quit immediately, the fact that he became more open to help shows that the meaning of smoking has started to change. Besides, he stated that he feels similar to others after surgery is also meaningful. It suggests that he is still negotiating his self-identity if he is trying not to define himself as a weak and permanently ill people. This shows that illness is not only a physical experience, but also a process of identity adjustment. Through reflection and interaction, he is gradually rewriting the meaning of himself as a person living with chronic illness. This theory fits Mr. M's especially well because his illness experience influenced meaning making, social identity, and gradually behavioral change. It helps explain why he did not change immediately, and why his progress depends on how he interprets his condition and support around him. His behavior was shaped not only by symptoms, but also how those symptoms affect his sense of self and daily interaction.
Hello everyone, I'm Cheung Wai Lung. For this reflective video, I'd like to share my learning from the case of Manira. To begin with her background, she is a 39 years old Nepalese housewife with no known geology, and she is a non-smoker, non-drinker. And for her social circle, she's got married. She had 5 children and lived with her husband and 5 children in Taiwan public housing. Her father passed away for last few years, and for her education level, she has a Form 5 education level. She is a full-time housewife, and for the socio-economic status, she is in lower middle class. And for her past medical history, she was diagnosed with hypertension with 4.5 years ago, and she also has some kidney problem and forgetfulness. And for her illness experience, her medication adherence is inconsistent. Her mind will automatically invent problems even during free time, making it very difficult to relax. She is used to giving almost all her time to family and is lead to ignoring her own self-health condition. Poor emotional regulation also lead to chronic anxiety and rumination. Just attend the Eastern Hospital to do following ups regularly, though she worries about the long waiting time, and she relies on sleeping rather than the structured relaxation techniques during BP spike. And I would like to use social determinant of health to explain the patient case, which is based on non-medical factors that influence the patient health outcomes. Firstly, from economic stability dimension, the patient lives in public housing in Taiwan and is from a low-middle socio-economic background. There isn't a significant financial crisis. Her mother and oldest doctor occasionally provide financial help, but for the main breadwinner is her husband. However, the recent increase in HA medical bills has caused her to experience minor financial stress, which she indirectly links to a worsening of her BP. Even though the family is not in poverty, as a full-time housewife with 5 children, she is under consistent stress from living and medical costs. Her nervousness and unwillingness to use too much medication may be influenced by these minor but enduring financial worries. For the second dimension, education, she has a Form 5 education level, which contributes to a limited health literacy. While she can still demonstrate some health behavior on her own, like monitoring home BP regularly and using the HA Go to check the follow-up, she still holds several misconceptions regarding to her condition and treatment, ranging from forgetting those when anxious, occasionally want to take extra medication to speed up recovery, to believing that sleeping can quickly resolve high BP readings. This gap in understanding combined with high anxiety appear to significantly affect her medication adherence and self-management of hypertension and kidney disease. For the third one, health access and quality, she received care through the public healthcare system, primarily at Eastern Hospital. She finds the HA Go app is useful for paying bills and managing some surveys online. However, she thinks the long waiting times at hospital and the recent increase in the medical fees are a bit annoying to her. There are also the factors causing her high BP and stress. She was diagnosed with hypertension 5.5. She was diagnosed with hypertension 4.5 years ago, along with the subsequent findings of kidney problem. Although she has attended a dietitian season, the consulting highlighted her fear rather than empowering her. This factor have also contributed to anxiety-driven medication behaviors and delayed comprehensive self-management education to her. And fourth dimension, social and community context. As a Nepalese ethnic minority in Hong Kong, she has a relatively small social circle outside the family, causing her life to revolve almost entirely around her family. She needs to carry a heavy caregiver burden as a central figure managing 5 children, spanning a wide range from 4.5 years to 22 years. As a only 39 years old woman. She received reasonable practical and financial support from her husband, mother, and eldest daughter. However, emotional support is primarily from her eldest daughter, and there is also very limited support from her friends. And she is accustomed to devoting almost all her time to her family. Even during free time, she tends to ruminate and inventing problem-making realization difficult. This chronic road overload and limited social support have resulted in persistent anxiety, emotional tension, and psychosocial stress, which likely contribute significantly to her sustained hypertension, forgetfulness, and medication inconsistency. And for the last dimension, neighborhood and built environment, she lives in public housing in Taiwan with her husband and 5 children. She has convenient access to public transport, but she actively chooses to walk instead of taking bus. There is no big issue with the air quality and nighttime traffic noise around her apartment. Her apartment isn't big with living with 5 children. This limited the area during exercise at home. This one of the factors that worsen her health condition. Even though she wants to do some basic exercise, maybe like yoga at home, the limited space doesn't allow it. However, she has rated Hong Kong as a fast-paced lifestyle and a stressful city. During a recent holiday outside Hong Kong, she experienced a significant reduction in stress. Upon returning, her stress level increased again, which she attributed to Hong Kong living environment and daily pressure. She finds temporary relief when escaping the city and reports that walking and revealing natural scenery helps her feel calmer. A modern urban lifestyle is also a contributing factor to her chronic stress and elevated BP. To sum up, with the 5 dimensions of social determinant of health is resulting to the patient health behavior that her medication adherence is inconsistent, and her mind will automatically invent problems even during the free time, and she will sometimes ignore her own self-health condition by spending most of the time to her family. And there's also poor emotional regulation. This may lead to chronic anxiety and rumination. And by her limited education level, sometimes she will use some unscientific support techniques to help with her condition, like during the BP spike. And that's all of my presentation. Thank you.
My name is Fong Wang Ren. My student number is 30363999029. And today, my patient is Mrs. Wang. For her background, she is an 68 years old woman, lives with her husband and has 3 daughters. She is socially active in community rehabilitation center in Lamtin and sometimes volunteers in hospital, which give her some social support and a sense of purpose. However, her caregiving role, financial worries, and frustration with health service contribute to emotional strength and make self-management difficult. And for her clinical history, she with complex chronic illness history including type 2 diabetes mellitus for more than 40 years, hypertension, hyperlipidemia, herniated intervertebral disc, and she has developed diabetic complications such as cataract and retinopathy. And she also has recurrent depression with relapse episode linked strongly to caregiver stress because she cares for her husband who has had multiple stroke and mild dementia. And today I will use the health-seeking behavior to talk about her illness experience. And for example, Mrs. Wang usually opens elderly center and community rehabilitation center regularly for the practical activity like exercise and nutrition talk. And she also prefers practical action-oriented service like dietary advice and exercise. And she avoids depression-specific service because they feel useless. And she has self-adjust medication instead of seeking professional advice, like this indicating low trust in some medical seeking due to conflicting information from doctors. And I will use the stress process model to explain her illness experience. For the stressor, there are 2 parts. The first part is direct illness and family demand, and there are chronic multiple morbidity like 40 years of diabetes, hypertension, hyperlipidemia, and herniated disc. These are the constant symptom management. And for the recurrent depression, episode in 2013 and 2025 with suicidal thought and anger towards her husband. And for the caregiver burden, caring for her husband with stroke and dementia cause emotional conflict, like she will think that she doesn't want to live with her husband, but her husband can't live without her. And for the second stressor, there are system and practical burden. And for the financial strain, the cost for activity and stroke rehabilitation subsidy are hard to get, and she got a delayed MRI due to the expensive cost. And for the healthcare access issue, there are long waits for follow-up and the time for consultation are short. And for the comforting medication advice, and because different doctors give varying information, causing confusion about medication and diet. And for the mediator, and for the social support, she has 3 daughters, which give potential emotional and practical support. She participates in community center and hospital volunteering, where friendly staff and social worker provide encouragement. The support from this network can reduce stress and make health seeking feel safer. And for the religious coping, her Buddhist belief help reduce the suicidal behavior and give her emotional comfort during the depressive relapse. And this function as a coping resource that help her endure the stress and maintain hope. And there are also communication, participation, sense of meaning and role, and self-efficacy and confidence. And for the outcome of the stress process model, there are emotional outcomes. She has recurrent depression with relapse in 2013 and 2025. And she also feels resentment, exhaustion, frustration, and emotional overload from caregiving and health system problem. And there are also selective health-seeking behavior. She uses practical community service but avoid depression-focused support when it feels repetitive or useless. She also self-adjusts medication, which show reduced adherence and unsafe coping with illness. And also there are reduced quality of life and role strength in her family. Thank you.
So my name is Ho Yin, and serial number 30364489850. So for the part B, I'm going to discuss about Fong Wang Ren's patient. For a quick recap, Mrs. Wang is an older woman with long-term chronic illness, including type 2 diabetes for over 40 years, hypertension, and also hyperlipidemia. He also had diabetic complications such as cataract and retinopathy, but recurrent depression linked to the caregiver stress because she looks after her husband, who had multiple strokes and mild dementia. Socially, she lives with her husband and has 3 daughters. She is active in community rehabilitation centers in Nanjing and sometimes volunteer in hospital, which gives her some support and purpose. However, her caregiving burden, financial worries, and frustration with healthcare service make self-management difficult for her. Her main illness experience is medical non-adherence and depression. She sometimes adjusts medications by herself, and her use of service is selectively because of side effects, conflicting advice, long waiting time, and emotional fatigue. Overall, she has some awareness of her condition, but stress and burden of multiple chronic illnesses make consistent self-managing more and more difficult for her. Moving on, I would like to use medicalization to explain Mrs. Wang's illness experience. One important illness experience is her medical non-adherence. Medicalization helps explain that Mrs. Wang's non-adherence is not simply carelessness or refusal to follow instruction. Instead, it reflects how her whole life has been organized around medical treatment, diagnosis, and repeated professional advice. She has lived with multiple long-term conditions for many years, so medication, follow-up visit, and symptoms monitoring may feel like a constant burden rather than a source of relief. When she adjusts her own medication, this can be understood as a way of regaining control in a life that feels heavily controlled by a medical system. She may be trying to cope with the side effects, confusion, instruction, and treatments that do not fit well with her daily responsibilities. From this perspective, non-adherence is not just an individual failure, but also a response to the pressure of living under continuous medical management. Medicalization also means that her body is being closely watched and classified through diagnosis. Because she has diabetes and hypertension, etc., almost every part of her daily life can be interpreted through a medical lens. This can make her treatment feel endless and exhausting, which may reduce her willingness to follow every instruction strictly. Moving on to the next part, Mrs. Wang's recurrent depression is another key part of her illness experience. Medicalization helps explain how her emotional distress is often treated as a medical problem, while the deeper social issue may be overlooked. Her depression is strongly linked to caregiver stress because she takes care of her husband, who has multiple strokes and mild dementia. She shows that her distress is not only a personal or psychological problem, but it is also a social crisis. From a medicalization perspective, depression becomes another condition added to her already a long list of diagnoses. Instead, who fully addressed the burden of caregiving, emotional exhaustion, and family pressure, the healthcare system may mainly focus on diagnosis and treatment. As a result, her depression may feel like another problem to manage medically rather than a signal that her social load is too heavy. So medicalization can make depression seem like a problem inside a person, when in reality, it is also connected to her environment and responsibility. This is important because it may explain why she feels tired, overwhelmed, and sometimes unwilling to keep engaging with treatment or repeated emotional counseling. This theory helps show that Mrs. Wang's problem is not simply a personal weakness. Her non-adherence and depression are shaped by a life that is already saturated with medical labels. Treatment demands and caregiving shrink. Medicalization allows you to argue that her difficulties come from the way illness has taken over many parts of her life, not just from a lack of discipline or motivation. Thank you.
Hi, I'm Cheung Wai Lung. Now I'm going to do the puppy patient reflection video to my cremate case, and I'll do the reflection with my cremation Ho Yin case. Her patient called Mr. M. For the quick recap, Mr. M was diagnosed with pneumoconiosis in 1980s. He was suffered a pneumothorax in late August with surgery done. He currently experiences chronic SOB, prolonged coughing, and chest tightness. He is a chronic smoker. He smoked around 15 cigarettes per day, and he has no intention to quit smoking. And I would like to use Strack-Horses model to explain Mr. M's case. For the meaning of Strack-Horses model, that means Strack is not just a single event, but a dynamic process involving interaction between structures, that mean the problems, the mediator, that mean the results and health coping, and finally the outcomes, that may be the health impacts. And for the Mr. M case, we have discovered that the structure may be the chronic respiratory illness that is a persistent SOB, prolonged coughing, and the chest tightness, and also reduction of physical activity after surgery due to the pneumothorax in late August. And after that, the ongoing risk of the deterioration and complication create a persistent health threat to him is also one of the structures. And there is also a estrangement from 5 adult children to the Mr. M, and there's also some financial strain may cause stress to him. For the mediator, Mr. M has strong spousal, neighborhood, and friend support, and she has also a trust fund and health vouchers. And besides that, he has received some support and tips from the doctor to let him realize that his case is normal. And for the outcomes, he has accepted and normalized his chronic illness. He attended regular medical follow-up in public hospital. He maintained a good and supportive relationship with his wife. And he also participates in morning tea and gathering with his neighbor and friends. And for the last, now he shows more willingness to do exercise. And that's all the detail of the structure, mediator, and outcome to explaining Mr. M cases by struct process model.
My name is Fong Wang Ren. My student number is 303639929. And today I'm going to talk about Cheung Wai Lung's patient, Munira F. And for the patient clinical history, she is with hypertension with followed upon 5 years and kidney problems and forgetfulness. And for the social history, she is Nepalese, married mother of 5, living in public housing in Hong Kong, and limited support outside her family, modest education, and significant caregiving and cultural stressor that affect her health. And the main illness experience is the medical non-adherence. And for her illness experience, I will going to use the chronic illness experience to explain this experience. And for the first part of the chronic illness experience is about the biographical disruption, and there are loss of normality. The hypertension has broken the taken for granted flow of Munira daily life, forcing her to reorganize her routine around blood pressure monitoring and medical follow-ups. And the threatened identity is about her identity as a strong, independent caregiver for her 5 children is challenged. She now feels vulnerable and anxious and dependent on family support. And the bodily trust is about her experience of palpitation, kidney-related fear, and high blood pressure make her body feel unpredictable and unreliable, leading to emotional distress. And for the second part is the managing symptom and regimen, and there are treatment burden. Managing her medication is not just a medical task, but an ongoing stressful labor that competes with her daily caregiving duties. And the rationalized non-adherence, which also say that her inconsistent use of medication, forgetting dose during anxiety and wanting to take extra dose, reflecting an attempt to regain control and navigate fears about what too much medicine might do to her body. And the active coping, she attempts to manage the condition through non-medical strategies like walking, hiking, yoga, and breathing exercise, demonstrating a desire for self-control and stress relief. And the last part is the strain on family member. And for the reshaped role, her illness has redistributed household responsibility. Her eldest daughter and husband are now essential to her care, managing finance, housework, and medication reminders. And for the family interdependence, the family system is under pressure because they must support Munira health. This on top of their existing household demands, creating an uneasy balance of care. And for the invisible labor, the emotional and practical support her family provide is a critical mediator, but it also highlights the stress and reliance that chronic illness places on the entire family unit. And this theory shows that the Munira non-adherence is not a simply personal failure. It's shaped by stress, limited support, and social position that makes the analysis more critical and less blind-oriented than the sequel alone, which can be provided victim blinding if patients are judged only by compliance. The social gradient of health also helps explain why her public housing setting, minority status, education level, and access to care matter for illness, experience, and outcome. Thank you.